I'm recording this intro in Wanaka, New Zealand at our Vets on Tour conference. Morning lectures have just finished and I'm about to head up the mountain with a bunch of our delegates, who I'll be hanging out with for the rest of the week at our conference venue and on ski lifts and in a sauna and all sorts of exciting places. But I also get to spend time with the representatives of the sponsors who support Vets on Tour. One of those sponsors is IDEXX. And last year in Wanaka, a hot topic of conversation on those ski lifts with Justin, who is our Vets on Tour IDEXX vet, was their new cancer DX test, the Canine Lymphoma blood test. I had many questions about it, and eventually Justin said, I know some oncologists, do you want to chat to someone? Enter Dr. Sandra Nguyen, an oncologist from Sydney, who had the answers to all of my questions. That conversation became an episode on our clinical podcasts, and because it's been a minute since I've shared any of our clinical content on here with you, and in celebration of the fact that I get to pester Justin again about all things diagnostics, while also laughing at him as he continues his ski lessons, I am making this episode available right here. Remember that if you like this sort of clinical content, we have more than 600 clinical episodes with show notes over at thevetful.com. Just click the clinical content button. Okay, let's get into cancer testing with Dr. Sandra Nguyen. I hope you find it as useful as I did. Please enjoy.
So they've definitely gone and picked like the most common and the one that we care about, and it can kill them pretty fast.
Dr. Sandra Nguyen, thank you so much for joining us on the Vet Vault.
My pleasure, Hugh. Thank you so much for having me.
So we want to talk about cancer testing. I've done previous episodes on the broad principles of it, but we want to dig into the cancer DX specifically. Mm-hmm. But in this test, we're going to talk about sensitivity and specificity. And for some reason, I find most vets, or many vets, have a mental block against understanding which is which, and then also really understanding what it means. So can we start just recapping those concepts so that to frame the rest of the conversation? You said you struggle with it as well.
Oh, yeah, I absolutely. It's not exactly my favorite subject. How do you think about it?
Okay, so I was trying to think of a way to think about it for people to remember it. So I thought of this last night. Let's test it. Tell me what you think. So if you think about a person being sensitive, we talk about, oh, she's very sensitive. So let's say sensitive to an insult. So Hubert is very sensitive to insults. If, let's say I'm 90% sensitive, if 100 people insult me or they offend me or say something rude, 97 of them I'm going to pick it up. I'll be like, yep, that person insulted me. Versus somebody who's not that, is pretty chilled and not that sensitive will miss a bunch of them. People will actually insult them, make a snide comment or something, and a bunch of them they'll miss. They're not going to realize that they've just been insulted. But now a friend says, hey, Hubert, you are clearly very sensitive about these things, but you also need to be careful to be specific. And I say, well, what do you mean with I need to be specific? And the friend explains and says that, well, you need to be able to identify when somebody is actually not insulting you. So imagine you're speaking to 100 people in a day and none of them actually meant any harm. They didn't say anything rude. They weren't having a dig at you. Are you specific enough to recognize that there were no insults? Because if you're not specific, you're going to start thinking that somebody insulted you when actually they weren't doing anything like that. So in diagnostic terms, just to clarify then, a sensitive test is good at picking up disease that truly is there, like an insult. In other words, it's going to be a very sensitive test is going to be less likely to miss a disease versus a specific test is good at correctly telling you that that patient does not have disease. In other words, it's less likely to call out disease when there's actually no disease present. Is that right? Does that make sense?
Yeah, I think so. And you're going to, if you're super sensitive and not very specific, you're going to get loads of false positives, just like you said. You're going to be super insulted all of the time to nothing, really.
Yeah. Okay.
Yeah, I like that. I like it's quite emotive too, so maybe I'll actually remember that way around.
Okay, cool. Let's see if that works. I am going to interrupt myself here. This whole conversation about sensitivity and specificity has sent me down on rabbit holes again, as it does. I've found a couple of other bits of information. And there's one thing I want to add that I did find a nifty way to remember sensitivity and specificity. So it's called snout and spin. Snout is SNNOUT. And that means for a highly sensitive test, SN, sensitive, a highly sensitive test when negative, the second N, rules out the disease. In other words, in a test with 100% sensitivity, if I have a negative result, it means the patient does not have the disease. SPIN, SPPIN, which stands for a highly specific test, SP, when positive, P, rules in the disease. I hope that helps. So now let's get into Cancer DX, which is the new IDEXX cancer test.
Blood test.
So I'll tell you what I think I know, and then you tell me if that's right. So it is a blood test, right? So
Correct.
Send away blood test. It's not an in-house. Yep.
It's not an in-house yet. No.
Yeah. And currently just canine lymphoma. I got that right.
Just canine lymphoma. They are hoping to add a couple of others relatively quickly.
Okay, but for now,
canine lymphoma.
Canine lymphoma. If they really want to make it useful, they should make a feline lymphoma.
Well, yeah, true.
And the principle, it looks for snippets of cancer DNA. Is that right?
Well, that's still, we don't know, essentially. That's still proprietary. So we don't actually know what proteomics they've used or what they're actually looking at. So that's my assumption, is they're looking for the DNA of the lymphoma.
That's like cancer testing in general.
Yeah, correct.
That's generally how it works, right?
Yeah. Correct.
And some of the other veterinary ones out there as well, they're looking for small sequences of...
In the liquid biopsies?
Yes.
Yeah.
Okay, so we're assuming... I didn't know we didn't know how it works. Okay, and we just talked sensitivity, specificity. What's the advertised sense and spec for this test?
Sensitivity is around 80%. Specificity is 99%.
Okay, cool.
So if it's positive, it's probably positive. If it's negative, 1 in 5 will miss them.
Gotcha. So putting that in numbers, if I test 100 dogs that actually have lymphoma, it's going to miss 20 of them. It's going to say 20 of them don't have lymphoma.
Don't have lymphoma when they actually
do have it. But the positive tests, almost all of them will be accurate.
Actually positive, yeah.
1 in 100, it'll say, do you have lymphoma when you don't?
Correct.
Okay, cool.
And then just to compare that to cytology, so that's our other mainstay of how we diagnose this disease.
So FNA.
FNA, yeah, correct. FNA, not histology, FNA. So the sensitivity of that is around 93% and the specificity is around 90%.
Oh, so and we'll sometimes call something lymphoma that's not, if I send an FNA away. I suppose, but if you look at lymphocytes, they can sometimes look really, really nasty when they're actually just sad. They're just upset.
Yeah, they're very upset. Yeah, correct. Exactly right.
Yeah, okay, that makes sense. Okay, but that's always when I've spoken to the IDEXX crew about this test, I always want to go, well, why do we need it? Because if I think about, I suppose there's a couple of scenarios. The one is the dog that comes in to consult where either it's unwell and I do an exam and I go, oh, your lymph nodes are up, or the dog that comes in for skin check and I go, oh, shit. Or the owners will come in and say, I've noticed these weird things on my dog. And then I go, well, I will stick a needle in. It's not a hard test to do. FNA, bang, you have your answer. So that's the first question is, why do we need this test if we already have cytology?
Yeah, I think in the diagnostic space, there's 2 places where this test is useful. One is in that early cancer detection phase, which is part of the reason the sensitivity has been sacrificed for specificity in some ways, because you don't want to be giving people false positives for lymphoma.
Okay.
So those breeds that are predisposed to lymphoma, which are like the Goldens, Beagles, Boxers, Mastiffs, Labs, Rottweilers, and Border Collies in this country. I think when you're doing your yearly screening at, say, 5 years on, you can just add that Cancer DX to your total annual health profile. Senior wellness pet check, you add your Cancer DX on, and if you get a positive, well, then you get to be eagle eye on that dog, even if it's asymptomatic now. And then the other case where I've found it useful, especially for our medics in the veterinary world, is where you've got this sick dog
Mhm.
that potentially has like a mediastinal lymphoma, or just like you're saying, subtle lymphadenopathy, skin disease with lymphadenopathy. Well, on cytology, those lymphocytes may well look sad, but might not be lymphoma. Well, you can do
Mm.
a cancer DX, and if you get a positive, well, you've got a lymphoma diagnosis.
True. Yeah, you're right. They're not always. You get those super obvious ones where I kind of do the FNA just to have it
Yeah.
in black and white, but you kind of know what's going on based on your clinical. But
For physical exam, absolutely. And I think that's probably, and that's even how we really measure remission too, is basically a physical exam. I don't FNA my in
oh,
remission patients. It's if the lymph nodes are back to normal, we call them in remission.
oh,
So those dogs that are presenting sick, say, and the next step really is advanced imaging, that's going to cost you maybe 3 to 4 grand for a CT scan, blah, blah, blah. Well, you could also, if it's one of those at-risk breeds and you're concerned for lymphoma, along with your samples you're sending off anyway, you could test for cancer, for lymphoma.
okay. Okay, so let's do this two buckets just to be very clear. So let's do sick dogs first, and then we'll do screening. We'll recap screening quickly. So sick dog. So you said the subtle one that's not that obvious, because you do have those cases where you go, you kind of smell like cancer. Something's cancery about this dog, but I can't find it. Do this test, comes back positive.
It's lymphoma.
99% of the time, it's going to be you have your diagnosis. It's
Yeah.
specific enough that I have my diagnosis. I can refer.
Yeah.
I can send it to Sandra. Fix it.
And maybe, yeah, absolutely. Yeah, I'll definitely fix it, or I'll hopefully put it in remission. So those cases where the blood work doesn't scream lymphoma, but it's cancer, as you say, so you've got some cytopenias or even some cytoses, and you're not quite sure what's going on, febrile, dyspnea, that sort of thing. And I think GI lymphoma can also be hard to diagnose in
Hmm.
dogs, just like cats, like you were just implying in cats. So it kind of reduces the amount of advanced testing we would have to do in the patient. So I think getting to the diagnosis through a blood test can be helpful in that way.
Okay, so that makes a lot of sense to me. That I go, okay, cool. That's an awesome test for that. Now the obvious one. Let's say I have the dog comes in unwell or well, big lymph nodes. So do we FNA or do we do this? Because again, it's super, super specific. So I'm going to, if I decide to go cancer DX versus FNA, I'm going to get my answer. Is in your hands, which do we do? Or is it a both scenario?
It can be a both scenario, mainly for me in this early phases of testing it and
Mm,
checking it.
mm,
So, a bit like I was saying before, oncologists can be relatively cynical and
mm.
a little tough to convince of whatever we're going to be changing our practice and why. So, for example, when I first put in the IDEXX InView machine, which is the in-house test, which looks at the smears
Yep.
in-house rather than having to send them away, I was doing smears side by side and checking it.
Hmm.
So at the moment, I kind of do them side by side to check it.
Yep.
In the case that you're talking about, I think if you're getting blood anyway and the dog would need to be sedated for the aspirates, then I
Hmm.
would just do the cancer DX test.
Okay.
The reason I like the FNA in those situations when you think it's going to be lymphoma anyway is because we can actually do immunocytochemistry on the slides.
Yeah.
And Cancer DX can pick up phenotype, but not in as many cases as the cytology will.
Okay.
And the reason I care about immunophenotype in the dog specifically, multicentric lymphoma, is because, at least in our hands at SASH, we would actually change the protocol we use for the patient.
Yeah, you're going to treat them differently, whether it's T or B.
B or B, yeah.
Yeah. So I'm just trying to figure this out. So let's say I'm on Saturday at the emergency clinic. I have a case that I'm pretty sure. What's the turnaround time for the cancer DX in Australia? Is it quick?
3 days.
Oh, so
Yeah.
it's fast. I'm just trying to think how I would handle this. So you might, because I'm still going to look if in clinic, I like FNA, as you say, specifically if you don't have to sedate, if it's an easy enough patient. I'm going to look at it in house. That's going to give me I'm not going to call it on my own cytology, but it'll give me a very solid idea. I'm like, oh, yeah, that.
And I get to talk to
very
the owners
nice.
about this. Yeah.
And then we can say,
Yeah.
all right, I'm pretty sure, but we're going to confirm it with either FNA. What did we say FNA was specificity? 90%. So the cancer DX is better in terms of the
Specificity,
specificity. So you'd probably
but
want to
not
say
as sensitive.
not as sensitive. So both kind of does make sense. I think if you want to be very sure, right? Once you go, before you go
Yeah.
down the path, if you have an option.
Yeah.
Yeah.
And I think as an add-on, it's about $30.
Yeah, exactly. It's not like it's a major
So it's
expense.
not, yeah, correct. I think cytology is actually probably more
It
expensive.
is.
So it also depends on what the owners have shared with you around costing
Yeah.
and next steps. Because if it's $30 compared to cytology, which is a bit more, then that might be another, like as in they're not going to treat, we're just going
True.
to do
True, true,
pred.
true. Yeah,
That
let's
might
say.
be another reason.
Yeah, it's a good point. So dogs in the consult room, big lymph nodes. I say to the owners, look, based on clinical examination, I think your dog has a lymphoma. It's a type of cancer. It is potentially treatable. Do an in-house smear. That's $30 or $50, whatever you charge. I go, yeah, it certainly looks lymphoma-ish to me. And then get a vibe from the owner. Are you likely to go for chemo or not? And if they go, no, I don't think I'm going to go the chemo route, then there's no real benefit in knowing whether it's TLB. Then you go, well, let's send the cancer DX. It's nice and cheap. So we know definitely, yes, it is lymphoma. And then we talk about, are we going to put your dog on bread?
Yeah, exactly. And then the other caveat to that is owners change their minds. So in those situations, what I do is, because they even change their minds with me, is actually keep those slides that you've taken already.
Gotcha.
Because if I start the dog on pred, lymph nodes go away, I aspirate them again, I can't get the immunophenotype, and they've now come back to me within the week and want chemo. And or your cancer DX hasn't come back, whether it's B or T cell either, because it couldn't tell.
Yeah.
Sometimes it can, but not as reliably as lymphoma or yes or no.
Yep.
So I keep those slides because then I send them off for immunocytochemistry if
Okay,
they
so
decide to go
they
ahead.
can sit on the shelf. There's no, you could do that
Correct.
a week or two later if you have to.
Yeah,
Oh,
just
that's a
don't
cool
keep.
pro tip.
Yeah, just don't keep them anywhere near formalin. So yeah, I definitely keep them on the shelf and then just send them.
Okay, that's really good to know. All right, so that's nice and clear. That's I now see the utility clearly. Like you, I'm cynical of anything new.
Yeah,
People go in and they're like,
honestly, I'm like, I just don't want to learn about a new non-steroidal anti-inflammatory. You like, I just think we have many of them enough. Like, so one of those comes out, and I'm like, oh, I have to learn about another one. Old dog, new tricks. I just don't want to know.
all right, screening. Screening is the one where I'm actually probably more cynical. And it's because some of the people I've interviewed over the years have said, yeah, be careful of screening because what are you going to do with the result?
Hmm.
What are you actually going to do about it? The first question is, Sandra, if you have a non-at-risk breed, so you said Goldies, Beagles, Mastiffs, Labs, Ruddies, are those it? Or
Boxes.
boxes? Of course, boxes. Yeah, they've got every cancer. 5-year-old plus, high-risk dog, screen it. If it's a non-risk breed who's older, would you still do it? Would you still screen? Is it worth it?
Probably because, so 1 in 4 dogs get cancer. 1 in 2 dogs that are over the age of 10 get cancer.
Wow.
And lymphoma is about 24 to, depending on what you read and where, 24 to 25% of canine cancers.
Oh, wow. So it's big. Okay.
Yeah, it's big. And it's like 80 odd percent of all of the hematopoietic cancers that dogs get.
Okay.
So
Big.
they've definitely, the IDEXX have definitely gone and picked like the most common and the one that we sort of care about. And it can kill them pretty fast.
Okay.
So I think, say, for example, you've got that boxer dog and it's come back positive, and then in 3 weeks' time, it's presenting for that non-specific malaise,
Gotcha.
blah, blah, blah. The lymph nodes aren't huge. Well, then that's probably lymphoma.
Gotcha. So can I quickly clarify, when we talk broad principle about liquid biopsies and that sort of stuff, we did learn that just because I've picked up some signal of lymphoma or whatever cancer we're testing for doesn't mean you have cancer. It means there were some cells or there are some cells in the body that have developed cancerous signs, but maybe the immune system have taken care of them. But the tests are so sensitive sometimes that they'll pick it up. So I had some cancer cells, but I might not have cancer as such. Is that correct? Have we got the same principle? Because I suppose if my client comes in and we run a test in the healthy dog and it comes back positive, do we say, okay, now we're going to really watch it, or your dog has lymphoma?
Oh, no, I reckon I would say we're going to monitor
For that principle?
for that principle.
Okay,
Yeah,
so
exactly
that's
right.
accurate. I understand that correctly.
Yes. And I think what I would then do is recommend physical exams every 4 weeks.
Other blood tests? Is there any point in repeating the cancer DX to see if they go clear?
Yeah, so I don't know the answer to that in the screening space. In the treatment space, that's where I'm actually really hoping that's going to help me. So at the moment, as I said to you, I feel their lymph nodes, they shrink down, like for the normal multicentric one, they shrink down and then I call them in remission and don't reaspirate. I occasionally get a patient where, like I've got a little Jack Russell at the moment called Tilly. She's clinically, physically in remission, but her platelet counts have just dropped on me.
Okay.
And often that can be just chemotherapy, blah, blah, chemo. But sometimes that's also an early sign of them coming back out of remission.
Okay.
And so they've only done the IDEXX have only at the moment at least released a study of 10 dogs that went clinically in remission, and then they did the cancer DX, and then the cancer DX was negative as well when it was positive at the beginning.
Okay.
And so I wondered if I do, I still don't know yet, but what I'm hoping that in the cancer DX space, like for Tilly, rather than me imaging her all over trying to look for the cancer, I'm getting a CBC every week anyway before I give her chemo. I send off the blood for the cancer DX, and if it comes back positive, well, then the thrombocytopenia is probably her cancer and not the chemo.
Gotcha.
And then that can help me switch up protocols.
Okay.
And if it came back negative, then great. It's not that, it's just chemo.
Okay. Are you hoping that this is how you can use it, or this is how you will use it?
I don't know that we are not using it like that yet.
Okay. So it's still
at least not
we
in this country. Yeah.
need more data on this.
Yeah, we need more data. We do have Joanna, who works at Sash in Western Sydney, said she had a patient that was owned by a vet nurse. So the vet nurse was actually sending off the cancer DX every week herself.
While on treatment?
While on treatment. Okay. Yeah. And it did go negative while on treatment. So, yes.
So for the screening, again, we don't know how it works, which doesn't help. But in theory, that scenario where we talked about where maybe there was some early cancer cells developing, but then the immune system actually sorted it before it progressed to an active neoplasia, you'd think that it would clear as well. It should.
Yes, it should go to negative.
But we're not sure yet.
No.
Okay.
And I also don't know that we'll ever have the numbers to test that.
Okay. So for now, if we're screening and we get a positive, then you said 4-weekly clinical exam check. Would you check other stuff? Like, are we checking calcium?
Yeah, so the screening, I kind of assumed the screening went out with the total annual health profile. So if that comes back with a positive cancer DX and hypercalcemia, well, you'll definitely have your diagnosis.
Mm-hmm.
If the dog's clinically happy, healthy, cancer DX is negative, and your total annual health profile is normal, then you're still going to miss 1 in 5 that have lymphoma.
Yeah.
But if it comes back positive, then it's likely to be positive. And so that's when I would be watching, if you've got, get the dog back in, feel its lymph nodes again, because maybe they were subtle at the first place, and with the benefit of the cancer DX positivity, they're actually big, if that makes sense.
Yep.
And then, physical exam every 4 weeks. Plus minus bloods, I would probably usually, like apart from the hypercalcemia, where most often you would still get increased thirst and urination as a clinical sign from the owner, but not everyone picks that up as an owner.
So the well dog that came in for screening with no big lymph nodes and a positive cancer DX test,
I'd sit on it. We're
not going hunting in terms of imaging and CTs and MRIs and stuff at this.
I think it would depend. That's going to be a little bit on owner preference, but because of what I do, if that was my dog, probably, you know what I mean? Like if my dog came back with a positive cancer DX test and was otherwise happy, I would stick her through the CT scanner. So I think that's still a reasonable thing for people to do, but I wouldn't go ahead with treatment necessarily.
Okay.
Not happy, healthy, small lymph nodes. But if I got a positivity, put Molly, my schnoodle, through the CT scanner and then found her big lymph nodes and a mediastinal mass, then
we're treating.
Yeah.
Okay. Because again, my whole view on why are we doing screening tests, what are we hoping to achieve with it? I always go, is it going to give me the benefit of getting in front of a disease before it becomes a serious disease. That ticks that box here, even though we might not treat immediately because it might not be an active cancer. You're right. If we then hyper alert and the dog becomes unwell at all, then
You're not waiting that 2 to 4 weeks or 6 weeks sometimes for them to get sicker and sicker and they've actually got lymphoma.
because the benefit of treating sooner, we know with lymphoma, if you treat them before they, am I right? I think I remember from a previous
Yeah,
episode. If you're an unwell lymphoma patient, your prognosis is significantly worse.
yeah,
Versus
exactly right.
if we can get you, if we are going to treat, we want to do it.
When you're well.
Okay.
Yeah.
That does make sense. Okay. Those are my questions. So I suppose in summary, yes, useful test, both diagnostically in the unwell animal and screening.
Yeah, I think we're going to know more and more about it as we use it more.
Yeah.
Because it's one of those tentative things. It's definitely been, so it's been available here since February 2026, and it's been available in the States for about 12 months.
So we're learning more about it. It seems to be useful, you using it, and we're hoping that potentially can use it more, as you say, for monitoring and those sort of things. But watch the space for the data, and then we'll probably have to chat again once they add some of the other cancers
tests
to it as well, once it expands just beyond lymphoma.
Because I think the ones that are really harder to diagnose, because you kind of identified at the beginning of this, most cases are multicentric, most of them present with large lymph nodes. Why do I need this test?
Yeah.
I think some of those cancers that would be really interesting to see if we can increase survival, if we can get ahead of them, is hemangiosarc. So many of them are presented with abdominal bleeding. If we could have a blood test to identify that early, well, who needs a spleen? Let's just splenectomize.
All right. Thank you, Sandra. That was super, super useful. I like having clarity on this. My skepticism is resolved.
Fabulous.